Andrew, why do so many energy videos talk about vitamin B1 like it is a hidden stimulant switch? If I already sleep and eat okay, is a Megadose bottle even aiming at the same biology as real thiamine work in cells?
Start colder than the thumbnail. Thiamin is a water-soluble vitamin your cells convert into a coenzyme used when carbohydrate carbon is handed into usable energy pathways. It is not caffeine, not a pre-workout stimulant, and for adults who already meet needs from food, Megadose bottles sell a different promise than preventing frank deficiency. The workable form is thiamine pyrophosphate, or TPP. It sits inside complexes like pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase, checkpoints that feed carbohydrate pieces into the citric acid cycle. When TPP is scarce, those gates clog, so glucose-hungry tissues such as brain and heart feel the accounting error first. That is why deficiency can look neurologic or cardiac, not merely like a mild afternoon slump.
Does a high-carb training day burn through B1 faster, or is that gym folklore? And how small are body stores, practically, weeks versus months if intake collapses?
Stores are relatively small compared with fat-soluble vitamins, so thiamine behaves like a short runway. Regular intake beats a heroic monthly pulse. Higher carbohydrate flux increases traffic through those TPP steps, which is why low thiamine eating plus lots of refined starch, or losses from vomiting and heavy alcohol use, can uncover trouble faster than casual wellness ads admit. For most mixed diets, food first still wins: pork, legumes, seeds, and whole or enriched grains. NIH-style fact sheets treat thiamine as a diet-solvable nutrient for the general public. A standalone pill is not automatically better just because the milligram number looks bigger on a label. An 8-week randomized trial in Singaporean adults swapping habitual protein foods for plant-based meat analogs versus animal meats found higher dietary thiamine intake on the plant analog arm. That supports attention to fortified products, but stay honest. The trial's standout blood changes were vitamin B12, folate, and selenium, not a clean thiamine status victory lap.
So, who is actually most likely to benefit from deliberate thiamine attention? Because focus gummy shoppers seem like the wrong customer if the real story is deficiency risk?
Before we map those risk groups, a boundary, new numbness, confusion, severe weakness, or cardiac red flags are clinical evaluation problems, not a shopping cart diagnosis from a symptom checklist video. NXI's broader caution still applies. Supplement evidence and product quality vary, and self-megadosing can delay the right workup. Higher yield contexts include heavy alcohol use, prolonged vomiting, severely restricted intake, bariatric surgery recovery, and some long-term loop diuretic regimens where urinary losses climb. A pediatric nutrition meta-context also reminds us selective diets can lower thiamine intake. Useful as a watch item, not a blanket supplement rule for every child. A 2025 systematic review of acute non-alcoholic nutritional neuropathies in high-income countries found thiamine deficiency in about 54% of hospitalized cases assembled. Weight loss, vomiting, bariatric surgery, psychiatric undereating, and hyperemesis showed up repeatedly. These neuropathies can mimic axonal Guillain-Barré, exactly why early nutrition recognition matters. That mimic risk cuts both ways. If ascending weakness is evolving, you need urgent clinical assessment, not a week of internet thiamine while you wait. Reviews warn nutritional neuropathies can trigger unnecessary IVIG or plasma exchange when the nutrition piece is missed, and the opposite error, skipping emergency care for a vitamin experiment, is equally unsafe.
After bariatric surgery, people also whisper about Guillain-Barré. How should I hold thiamine in that story without pretending a vitamin bottle cancels an immune neuropathy?
K-series reviews of post-bariatric Guillain-Barré-like presentations describe ascending motor weakness, sensory change, hyperreflexia, and sometimes autonomic issues. Reported care often layers IVIG or plasma exchange with nutritional repletion, including thiamine and B12, because deficiency and immune injury can coexist or confuse each other. At home, New neurologic deficits after surgery mean urgent evaluation, not a wait-and-see megadose. Even inside a plausible risk group, dose humility matters. In a triple-blind pediatric trial of children with heart disease on diuretics for at least a month, about 20% met thiamine deficiency criteria by TPP at baseline. 4 weeks of 25 or 50 milligrams daily did not significantly beat placebo on TPP change or ejection fraction. Furosemide dose still correlated with TPP shifts, and authors suggested some deficient kids may need more than 50 milligrams under clinical supervision.
So, outpatient-style doses looked weak there. Do the septic shock headlines saying thiamine helps survival and kidneys mean I should borrow that evidence for my own stacking stack?
The hospital signal is real enough to respect in context. A 2025 systematic review and meta-analysis of 6 randomized trials in septic shock, 438 patients, associated thiamine with lower in-hospital mortality, risk ratio about 0.8, and less renal replacement therapy, risk ratio about 0.48. That is critical care protocol evidence with 4 pathways and monitoring. Respecting that signal means not stealing it. Consumer megadoses for ordinary tiredness do not inherit those risk ratios, routes, or safety nets. FDA and NCCIH framing still matters here. Supplements are not proven substitutes for medical therapy. Products vary, and disease treatment claims need clinical standards the bottle aisle does not provide. Brain-adjacent evidence is also lane-specific. In Cambodia, lactating mothers in a double-blind RCT receive 0 to 10 milligrams of thiamine daily. Infant attention to infant-directed speech showed a small dose response, clearest at 10 milligrams. Important where maternal deficiency risk is high, not a universal baby brain booster for already sufficient settings.
What about stuttering supplements and Alzheimer mechanism videos that make B1 sound like a memory drug? What controlled human evidence should actually change how someone shops? Then where are the hard stops for self-supplementation? If I am pregnant, heading into surgery on several medications, or already have neurologic or cardiac symptoms, when does caution say stop guessing and get evaluated?
Use a 2-gate rule. Gate 1. If diet already covers thiamine and you lack loss or malabsorption risks, expect megadoses to do little for energy, longevity, or sharpness. Concise broader point that many supplements underdeliver on big promises applies. Gate 2. Persistent numbness, ataxia, confusion, severe vomiting, post-bariatric red flags, or complex diuretic heart care belong to clinicians who can test, replace, and rule out mimics. Food and fortification for the well. Measured medical thiamine when deficiency physiology is plausible. Never a substitute for emergency care.